Hi, everybody. I'm Dr. Jennifer Sumner. I'm a clinical psychologist and an associate professor in the Department of Psychology at UCLA. And my work really focuses on the intersection of mental and physical health, particularly cardiovascular health. And today I'm going to be talking about PTSD and SCAD. And the take-home message is that it's really real. So there's been more and more interest in appreciating and understanding the links between mental and cardiovascular health. And this was really nicely demonstrated by this scientific statement from the American Heart Association on the mind-heart-body connection. And what we see is that there's support for a bidirectional relationship between mental and cardiovascular health. So not only can poor mental health like depression, anxiety, and PTSD contribute to the first onset of cardiovascular disease events, but in turn, experiencing acute cardiovascular events can adversely impact mental health. Further, we see that poor mental health in the aftermath of these cardiovascular events has been associated with a worse course of illness. And so today we're going to be focusing in on PTSD, which is the quintessential trauma-related mental disorder. And so what we see is that trauma defined broadly is common. So the vast majority of individuals will experience at least one traumatic event in their lifetime. And when people hear about trauma, often what first comes to mind is that trauma is something that soldiers encounter in a combat setting. And combat-related experiences can certainly be traumatic in nature, but this is not the only context in which trauma is possible. And what we see is that the types of traumatic events are actually really wide-ranging in nature. Yes, trauma can happen on the battlefield, but it can also occur in our homes, in our schools, and on our streets. So in addition to combat-related traumatic experiences, trauma can include being exposed to a natural disaster, childhood abuse, an unwanted sexual experience, physical assault, a very serious car accident, intimate partner violence, as well as a sudden and catastrophic medical event like SCAD. So what exactly is PTSD? Well, according to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or the DSM-5, PTSD is characterized by symptoms in 4 broad domains. So the first domain is re-experiencing symptoms. This involves symptoms of re-experiencing aspects of the traumatic event. So it can include unwanted, involuntary memories about the traumatic event, nightmares or bad dreams about the event, flashbacks, feeling as if that event is happening again to you in this very moment, intense or prolonged emotional distress to reminders of the event, as well as physiological reactions to reminders of the event. The second domain is avoidance symptoms, so avoiding things that remind you of the traumatic experience. This can include avoiding thoughts and feelings about the event, so trying not to think about the experience, trying not to feel emotions that come up related to the experience, or avoiding people, places, situations, or objects that remind you of the event. The third domain is negative changes in thoughts and feelings. So this can include an inability to remember important aspects of the traumatic event, negative beliefs about oneself, others, or the world, inaccurate blame of oneself or of others for the event, persistent negative emotions like anxiety, sadness, guilt, or shame, lack of interest in things you used to enjoy, feeling cut off from others or emotionally detached or distant, or a persistent inability to feel positive emotions. And then the fourth domain is hyperreactivity. So this includes things like irritability or angry outbursts, reckless or self-destructive behavior, being watchful or on guard, hypervigilant, being jumpy or easily startled, difficulty concentrating, as well as trouble sleeping. And so symptoms in all 4 of these domains need to be present for at least 1 month after traumatic experience and also be associated with clinically significant distress and/or impairment in different domains in one's life in order to have a diagnosis of PTSD. And we see that most individuals who experience a traumatic event do not go on to develop PTSD. However, a sizable proportion do go on to experience emotional difficulties after these events. So it's been estimated that around 5% of US adults have PTSD in any given year. And in 2020, around 13 million adults were estimated to have PTSD in the United States. Furthermore, we see that PTSD is twice as common in women than in men. So it's estimated that around 1 in 10 women will develop PTSD in their lifetime, as opposed to 1 in 20 men. We also see that PTSD is more chronic, severe, and impairing in women than in men. PTSD may be an especially relevant mental health consequence for SCAD patients, in part because of the often unexpected and unpredictable onset of SCAD events. Furthermore, most patients with SCAD lack the traditional cardiovascular risk factors that may further contribute to the unanticipated nature of the diagnosis. And what we see is that a greater sense of unpredictability has been linked to heightened risk for PTSD after trauma. PTSD is also relevant for this patient population, given the sex differences of both prevalence of PTSD and SCAD, with both predominantly affecting women. However, there have been relatively few studies of SCAD-induced PTSD to date, and there have been some studies, but in more limited samples, so this really has been identified as an important area for future research. Furthermore, there are a number of ways in which SCAD-induced PTSD symptoms can manifest that might look different than PTSD symptoms that onset in response to a more external trauma, like combat. So for example, symptoms of avoidance might play out in terms of avoiding cardiovascular medications or physical activity that activates your cardiovascular system. In addition, hypervigilance symptoms may be focused more inward rather than outward. So for example, focusing on one's heart rate very closely. And so in the iSCAD registry, we sought out to address PTSD as a consequence of SCAD. And I'm very pleased to be able to share these findings with you today that were published this year in the Journal of the American Heart Association. So we had a total of 859 patients in the iSCAD registry who completed a baseline questionnaire of PTSD symptoms that were onset in response to their worst or most distressing SCAD event. They also provided information about whether they sought treatment for these symptoms, whether they had sleep disturbance, as well as disease-specific health status. So in this sample, it's predominantly women, nearly 94%, with a mean age of 52 years. And so collecting this information allowed us to address the following questions. Just how common is PTSD after SCAD? And we looked at how common this was both in terms of patients' lifetimes as well as current PTSD, defined as past month PTSD. We wanted to know how many patients seek treatment for PTSD symptoms and what kinds of treatments do they seek. And then finally, are PTSD symptoms related to sleep and disease-specific health status? So what did we find? Well, nearly 35% of patients in the registry met for probable lifetime SCAD-induced PTSD. And additionally, about 6.4% of patients met criteria for past month probable PTSD. And I really want to emphasize that these are higher rates than what we see in either the general population and even in other cardiac patient samples. So for example, a large recent study of middle-aged and older women estimated both lifetime and past month PTSD, as we did here in this current study, and they found those estimates to be at 10.5% and 1.5% compared to our nearly 35% and 6.4% in the iSCAD registry. Additionally, clinically significant symptoms of PTSD have been observed in approximately 12% of patients after acute coronary syndrome, 25% of patients after stroke, and 32% of patients after sudden cardiac arrest. So again, we're seeing relatively higher rates of PTSD in our sample of SCAD patients. Additionally, nearly half of patients with probable SCAD-induced PTSD never received treatment. And this is a really important treatment gap, and it mirrors other research demonstrating that a sizable proportion of individuals with PTSD do not get treatment. However, those patients who did get treatment, nearly 35%, they mostly sought therapy and from a psychologist or social worker. It's also important to note that nearly a quarter of patients whose SCAD-induced PTSD symptoms did not reach the level of a probable diagnosis, nevertheless reported seeking treatment. And so this suggests that even subthreshold symptoms of PTSD may be associated with meaningful distress and/or impairment in individuals' lives that may benefit from treatment. And then finally, we found that greater past month symptoms of PTSD were associated with greater sleep disturbance and worse disease-specific health status. So to summarize, our investigation in over 800 patients with SCAD in the iSCAD registry suggests that SCAD-induced PTSD symptoms are a common mental health consequence for this patient population. Additionally, we found that PTSD symptoms were linked to clinical characteristics that are relevant to course of disease, including poor health behaviors and a worse disease-specific health status. Additionally, I think these findings really suggest that increasing awareness and supporting communications with healthcare providers is really key if either you or a loved one with SCAD think that you observe symptoms of PTSD after this type of event. So I want to thank you so much for the opportunity to share this information with you today. If you have any questions, please feel free to reach out via email. My email is listed here, as well as you can reach our lab website if you're interested in learning more about the research that we're doing.